Good afternoon, everybody. Thank you for this very kind invite. I'm a critical care pulmonologist here at the Cleveland Clinic. I'm the medical director for the respiratory ECMO services at the Cleveland Clinic main campus. I will be discussing the Cleveland Clinic's experience with ECMO for COVID-19. The Cleveland Clinic is situated in the state of Ohio, which has a population of just under 12 million, and the hospital is located at the Cuyahoga County with a population of 1.5 million. The Cleveland Clinic has 18 hospitals, over 6,000 beds, just under 5,000 physicians, and 15,000 nurses. We've got under 2,000 physicians in training. We see about 9 million patients in the outpatient through all our regional hospitals. Just do under 200,000 surgeries a given year. And we have over just under 300,000 hospital admissions across our regional hospitals. This is the Ohio COVID data. The state of Ohio has, as of this morning, confirmed 1 million cases, over 10,000 ICU admissions. And over the course of the last few months, the Cleveland Clinic Health System has seen over 13,000 of these COVID cases. A fifth of all the ICU admissions for the state of Ohio was within the regional hospitals of the Cleveland Clinic. We had just under 2,000 patients who were mechanically ventilated for severe ARDS secondary to COVID-19 pneumonia, with a mortality rate of 36%. Our mortality rate for mechanically ventilated patients under the age of 65 is 20%. As of this morning, we have 7,325 cases in Ohio, and our cases continue to go up. Over the course of the next 15 minutes, I'll give you an overview of the ELSO data, pre-ECMO management here at the Cleveland Clinic main campus, selection of patients, our management of patients as ECMO bridge to recovery, patient management on ECMO, and time permitting, discuss 2 cases that we found rather challenging. And there are multiple platforms with which we deliver extracorporeal life support here at the Cleveland Clinic, but our workhorse is the Rotoflow. This is the data from the ELSO consortium, which is an apex body for extracorporeal life support services internationally. This is North American data, which shows an in-hospital mortality of 50%. The Cleveland Clinic Health Systems has a similar mortality. This includes our cases for VV ECMO, bridge to recovery, bridge to transplant, including our VA ECMO cases for COVID-associated myocarditis. This is worldwide data, and this is the most current systematic review and meta-analysis, and this is across regions, Europe, Asia, and North America, and this shows a mortality rate of about 37%. So the premise of ECMO support is to allow for lung recovery, prevent further damage to the alveoli, permit lung rest and lung recruitment. The ECMO supplants the mechanical ventilation as the lung recovers, with the eventual goal of weaning the patient away from mechanical ventilation. At the Cleveland Clinic main campus and the regional hospitals, there is an emphasis on pre-ECMO management of COVID. COVID-specific management includes use of antivirals, steroid therapy, and IL-6 therapy as indicated per guidelines. There is a use and subscription to high-flow nasal cannula and utilization of the ROX code to transition the patient to mechanical ventilation as if and when required. Non-invasive ventilation is used prudently with a view to limiting the tidal volumes to 6 to 8 cc's per kilogram per body weight. Once transitioned to mechanical ventilation, every effort is made to maintain lung protective strategy with a P-plat of less than 30 centimeters of water pressure and tidal volumes aimed at less than 6 to 8 cc's per kilogram per ideal body weight. Most patients, almost all patients, undergo prone position ventilation, and the sedation strategy during mechanical ventilation is such that it allows for ventilator synchrony. By default, here at the main campus, we default to a high PEEP strategy, but still maintaining the dictates of lung protection. Neuromuscular blockade is entertained only upon failure of sedation and significant ventilator dysynchrony. Attached here is the ARDS protocol and management guidelines, which have to be strictly adhered to. As we conceived the COVID ECMO program, we made some core assumptions. We knew we had limited assets, and this required a substantial investment of resources because we were diverting resources away from our cardiothoracic program. We anticipated the demand was going to be high, and it was imperative that we prioritize the indication when necessary. We also realized that the role of ECMO and optimal management for COVID is still evolving. But there were some key principles that we utilized to construct our program. The idea was to use a clinical decision tool, which was in play prior to COVID-19. Because we had multiple regional institutes all connected to the main campus, it was imperative that we have situational awareness, and this was done by course coordination and consultation. The plan was to direct the resources to those most in need. And the plan was for a select group of expert physicians to be involved in the decision making process. And as COVID epidemic evolved, the idea was to prioritize novel strategies that would come through with more research. We had ethical principles that guided our ECLS management, and the four included the likelihood of the patient's survival, increasing the number of lives saved versus patient's autonomy, a sense of fairness, and being overall transparent with our process. All COVID-19 SARS-CoV patients were for extracorporeal life support were triaged, with patients being assigned on the basis of primary and secondary triage criteria. These included primary triage criteria included the highest likelihood of survival and providing extracorporeal life support to those with a short-term need. And the secondary triage criteria included duration of life, the patient's duration of life, and expected quality of life in the patient post ECMO therapy. But we had most of our systems in place. We have a robust ECMO multidisciplinary team that rounds with all patients every day in the morning. That includes a cardiothoracic surgeon, a thoracic surgeon, a critical care pulmonologist, an intensivist, pharmacist, and respiratory therapist. A large group of us caregivers who are very vested with extracorporeal life support at the bedside. Our guidelines are laid and are imminently available for the entire enterprise to peruse. We also have an exhaustive ECMO training program that we've invested over the course of the last few years. But we were mindful about the pandemic, and we also had to devise a plan wherein which to change our selection criteria based on our operational stage. So we were concerned about losing circuits, losing nurses, losing perfusionists, and physicians to COVID-19 pandemic. So we changed our selection criteria over the course of the pandemic, depending upon what our operational stage was. We included age, we included BMI, use of mechanical ventilation prior to ECMO, other organ injury, use of vasopressors, the REST score, the SOFA score to help conceive a plan. The criteria for ECMO selection is drawn solely from the EOLIA trial, and we usually commit our patients once they've exhausted conventional therapy with a PF ratio of less than 50 for 3 hours, a PF ratio of less than 80 for 6 hours, and those with the pH of less than 7.25, assuming the patient is now failing conventional therapy. Our cannulation strategy at the bedside is usually a dual site, and we've shied away from a single site cannulation for most patients. More importantly, the emergent nature of this procedure allowed for rapid deployment of a dual site cannulation strategy at the bedside. And the plan on extracorporeal life support is to limit ventilator-induced lung injury, and we do so by decreasing the volume trauma, decreasing barotrauma, by decreasing the inflation pressures on the mechanical ventilator, preventing the cyclical collapse, utilization of high PEEP, and decreasing the oxygen toxicity while on ECMO. And the idea behind ECMO initiation is to decrease the power that's delivered from the mechanical ventilator to the injured lung. Over the course of the first 72 hours, our strategy while on ECMO on mechanical ventilation is a high PEEP strategy with a view to recruit, and the PEEP is titrated per the pressure volume curve as is evident on to your right. Patients usually undergo an echo at bedside to estimate their RVSP or the right ventricular systolic pressures as we titrate up the PEEP. And the PEEP is also titrated depending upon the patient's hemodynamics. And patients are subjected to low tidal volume ultra lung protective strategy, and the respiratory rate is lowered to between 6 to 10 breaths per minute. ECMO management is kept very simple. The sweep and the flow on the circuit are adjusted to maintain a pH of 7.25, PCO2 40, PO2 50, and SPO2 of about 85%. The fraction of delivered oxygen on the blender to the ECMO circuit is rarely manipulated. Our sedation goal is usually with a view to maintain vent synchrony and patient comfort in a view that the patient does not chug or allow for chattering of the circuit. And the sedation goal changes as the patient improves clinically. Neuromuscular blockade is only used if in case of significant dysynchrony and challenges in maintaining circuit flow. The Cleveland Clinic defaults to no anticoagulation strategy, only sub-Q prophylaxis as is done for critically ill patients in the medical ICU. This is following an internal review of our own data. Volume depletion with a view to dry the lungs based on the fact trial is embraced. Palliative care consult is initiated on day one of ECMO admission with a view to connect to palliative care staff, knowing well that only half of patients are going to survive as of now. And COVID-specific management is continued. Our blood transfusion targets are strictly at hemoglobin value of 7 and a hematocrit of 21, and with platelets of less than 20 unless the patient is bleeding. The rest is expected management as the patient slowly improves on the ECMO circuit. ECMO weaning happens as the natural lung improves with heightened CO2 elimination, increased oxygenation, and increased compliance. And in doing so, which is we limit the amount of blood that flows to the circuit, and we start dropping the sweep gas flow on the membrane lung. We usually initiate decrease in the sweep gas flow as the tidal volumes in the mechanical ventilator increase, and this usually correlates with chest X-ray improvement and improvement in the patient's compliance. Over the course of the next 7 days, it's the norm to decrease the PEEP, which is set high, assuming the recruitment has been completed. The FDO2, or the delivered oxygen to the circuit, is always kept at 100% of 1. The sweep is gradually lowered to 0 liters per minute over the course of time, and once at 0, the patient is usually maintained at 0 sweep for about 24 to 48 hours prior to ECMO decannulation. The ECMO flow is usually maintained at 2.5 liters per minute, never lower than that, in an effort to prevent clot formation within the circuit. This is a tale of two pregnancies, two cases that challenge us with different and differing outcomes. A 31-year-old female gravida for para 4, 27 weeks, was admitted to the outside hospital early in the month of April with COVID-19 pneumonia. She developed fulminant ARDS. She was treated with remdesivir and dexamethasone and with volume depletion. 5 days into a hospital admission, she underwent an emergent C-section for worsening hypoxia and non-reassuring fetal heart tones. A day thereafter, she developed leukocytosis, hyperoccal, CRP, and on the 4th of May, she developed bilateral pneumothorax. On the 7th of May, prone position was attempted at the outside hospital and was aborted because of rise in PCO2. The patient was supinated on the 8th and was treated with nitric oxide in an effort to decrease the PVR and improve the oxygenation. On the 8th, the patient was finally cannulated at the outside hospital and transported to the clinical main campus by critical care transport staff in consultation with our medical ECMO attendings. This is the X-ray on presentation. This was a dual side configuration. This is a dual side cannulation. On the 8th, patient arrives from the outside hospital with a 16 French right inflow reinfusion and a 25 French drainage cannula. Immediately upon arrival on transfer from the gurney to the patient's bed, the patient had a peri-arrest. They required emergent repositioning of the drainage cannula. A day after, here in our ICU, we realized that the patient has now developed head and was transitioned to bivalirudin. Over the course of the first 4 days in the in the cardiothoracic ICU, we struggled with ventilator asynchronous severe encephalopathy. On the 16th, the BAL revealed zygomycosis, and the CT chest a day prior had reported multiple cavities. This was an immunocompetent host who had gestational diabetes prior to admission. 17th, she ended up having a CT brain which was negative. She underwent a percutaneous tracheostomy on the 18th. Attempts were made to address the bronchopulmonary fistula with bronchial valves, but this was deemed to be futile. In an effort to limit the leak, the patient was transitioned off the mechanical ventilator directly to a trach column. On the 25th, the patient underwent an oxygenator change. On the 26th, in an effort to review the sinuses, a CT sinus was done which showed opacification of the sphenoid sinuses, but no evidence of mucor. This was a chest X-ray this was a CT chest on the 15th, which showed mucormycosis. By then, the patient was already committed to posaconazole and amphotericin B. As luck would have it, with time and treatment, the patient improved to the point where the bronchopleural fistulas healed, and we were eventually able to decannulate the patient On the 1st of June, the patient was transferred to the medical ICU from the cardiothoracic ICU on the 2nd, and the patient began to phonate on the 3rd. She was transferred to our advanced pulmonary service on the 4th. Chest tubes were removed on the 6th, and the patient was finally decannulated, underwent tracheal recannulation and tracheostomy, and was transitioned to room air. And at the point of discharge on the 7th to a long-term acute care facility, the patient was ambulating independently. I believe this is the first reported case of pulmonary mucormycosis that survived ECMO therapy. X-rays a month apart from when she came in and to a day before discharge from the primary pulmonary service. Case 2 was a 22-year-old female patient with a BMI of 36. She was 26 weeks pregnant, 25 weeks pregnant. She was admitted to the medical ICU at the outside hospital early in February. Underwent prone position ventilation with a gravid uterus. Was treated with neuromuscular blockade on the 7th. Blood cultures on the 8th were positive for strep pneumonia and enterococcus in the urine. 9th, bilateral DVTs were reported, and the chest X-ray showed evidence of subcutaneous emphysema with worsening of the PEEP. On the 10th, 5 days after admission, or 7 days after admission, the patient underwent an emergency section and ECMO initiation at the outside hospital. On the 11th, we were asked to accept the patient for further management. The chest X-ray is representative of the patient's clinical condition on arrival to the main campus cardiothoracic ICU. A few days after, she developed right compartment syndrome, underwent an emergent fasciotomy. A week later, she developed uncontrolled nasal bleeding, required ENT packing. She developed HIT, and she was committed to bivalirudin. But 4 days after development of HIT, things took a turn for the worse. She was at the upper limit of ECMO support. Within the next 24 hours, she developed a pneumothorax on that same day, on the 23rd. 24 hours into it, her lactate started increasing, and she was on high dose of vasopressors. On the 25th, a bedside abdominal ultrasound showed evidence of portal venous gas, and there was concern for likely bowel ischemia. On the 26th, she developed fulminant DIC. And then the 27th, her code status was changed to do not resuscitate. She finally died, and her rhythm at demise was asystole. Her chest X-ray never improved over the course of time that she was here with us at the Cleveland Clinic. These are my colleagues. It takes a village to run an ECMO program. These are the cardiothoracic intensivists that help manage the patients who take primary responsibility. This is my medical team, without which this program would not have been successful. We have the medical ECMO staff, all of which are trained critical care pulmonologists with subspecialty interest in interstitial lung disease, airway management, ARDS, and mechanical ventilation. We partnered with our lung transplant surgeons. Dr. McCurry is the director of the heart, lung, and the lung transplant program to conceive our ECMO program too. But we have thoracic surgeons and cardiothoracic surgeons as a part of the program. I thank you for your attention, and I'm happy to answer any questions through email if required to be.